Hi, my name's Bonnie Flemister, and I'm here to talk to you about abuse, neglect, and exploitation in nursing facilities. We need to be in every time identify it, prevent it, and advocate for the residents that you're taking care of. I'm a geriatric nurse practitioner and have worked in nursing homes and do not sit in an ivory tower and make up rules for you to follow. I understand what you do and want you to know that I appreciate everything that you do to take care of the elderly. So what is elder abuse? Elder abuse is a term referring to any knowing, intentional, or negligent act by a caregiver or any other person that causes harm or a serious harm to a vulnerable adult. CMS, Medicare, Medicaid, has defined abuse as the willful, listen to the word willful, infliction of injury, unreasonable confinement, intimidation, or punishment with resulting physical harm, pain, or mental anguish. Abuse also includes the deprivation by an individual, including a caretaker, of goods or services that are necessary to attain or maintain physical, mental, and psychosocial well-being. Instances of abuse of all residents, irrespective of any mental or physical condition, cause physical harm, pain, or mental anguish. It includes verbal abuse, sexual abuse, physical abuse, and mental abuse, including abuse facilitated or enabled through the use of technology. Willful, in this case, as used in the definition of abuse, means that the individual must have acted deliberately, not that individual must have intended to inflict injury or harm. It was not inadvertent or accidental. For instance, you have a resident who is upset and swings and hits another resident. That was intended to inflict injury. But if you have a resident with a neurological problem and his arms and legs are uncontrollable and he accidentally hits another resident, then that is not willful. So what do you think is abuse? What do you know about abuse, neglect, and exploitation, A&E? Which of the following are considered types of abuse? Physical, mental, sexual, financial exploitation and neglect. Neglect and financial exploitation are not abuse. They have their own categories, but fall under the abuse tag in long-term care. So what types of abuse are occurring? This is the type of abuse complaints in the United States nursing homes. You'll see that physical abuse is 29%, or 3 out of every 10 cases is physical. I also want you to notice that 22% are resident-to-resident abuse, and it's much more common than we think. In Oklahoma, more of us are getting older and living longer, and there also comes the distinct possibility of elder abuse. It's estimated that at least 1 out of every 10 elderly persons will be abused each year. The problem is that's not really good statistics because abuse to the elderly is not generally reported. 1 out of 3 child abuse cases are reported, but only 1 out of every 23 elder abuse cases are reported. It is our responsibility to report abuse. Oklahoma's long-term care staff are required to report suspicious of elderly abuse or neglect. The law requires any staff who believes that a resident is being abused, neglected, or exploited, they must report the circumstances. A facility employee or agent who becomes aware of abuse, neglect, or exploitation of a resident prohibited by the Nursing Home Care Act shall immediately report the matter to the facility administrator. Knowingly and willfully failing to promptly report is a misdemeanor crime, punishable by a fine of up to $1,000 or imprisonment of up to a year or both. Any person who willfully or recklessly makes a false report shall be civilly liable for any actual damages. So what we're saying is that staff has a duty to report abuse against vulnerable adults. They must report to one of the following: your supervisor, the charge nurse, the nurse manager, the administrator, the company hotline, which I will give you later, or the state abuse hotline. You cannot remain silent. Physical abuse is threatening or inflicting or the intent to threaten an elderly adult of physical pain or injury, or depriving them of a basic need. The examples are pretty obvious: arm twisting, burning, choking, force feeding. Okay, you need to pay attention to that. Improper use of chemical or physical restraints, rough handling, shoving, throwing something, beating, slapping, pushing. These are all pretty obvious examples of physical abuse. The physical signs are sometimes obvious: abrasions, bite marks, okay, broken bones, bruises of different colors, burns, change in a functional status, dehydration, malnutrition, pressure marks, pressure injury, and every lawyer in the country would like to be told about that, and unexplained, repeated, unexplained, and unexplained injuries, and unusual weight loss. There's also emotional and verbal abuse. That's inflicting mental pain, anguish, or distress on an elder person through verbal or non-verbal acts. Raising a fist, making gestures, all of those are emotional abuse. Mental and emotional would caused by humiliation, harassing a resident, insulting or putting them down, threats of punishment, preventing them from seeing their friends and relatives, and isolating them from their social contacts. Verbal abuse is using oral or written or gestured language that willfully disparages or derogatory terms to residents and their families within their hearing distance. Age and ability and disability. One of the things that can happen is two people standing outside of a resident's room arguing, and even though the resident may not hear the exact words, they know that there's anger, and they could be frightened that they were going to suffer some kind of abuse. Residents are not your children. We don't honey and we don't sweetie. Yeah, we really do, but we get permission from residents for any kind of a nickname or any kind of a label that you find endearing, but they may not. You don't give them orders. You don't say, sit down and eat that. You don't threaten. You don't scold. And you certainly don't raise your voice. Psychosocial signs, but aren't all inclusive, is if you see a change in the residents' reactions to other caregivers or to other residents by acting submissive, or they become more aggressive. They might have a change in mood. You may notice that they're crying more. They may have a decrease in their cognitive behavior. They may begin to resist your care. They may decrease or refuse to communicate with you. Fear, hostile, loss of eye contact, nervousness, suspicious, or even vacant stares. Sexual abuse. Sexual abuse is a non-consensual sexual contact of any type with a resident. The perpetrator's staff. There's a sexual relationship between a staff member and a resident with or without diminished capacity may constitute sexual abuse. There should never be any kind of sexual contact between a staff member and a resident. Visitor to resident. In some situations, sexual activity between a resident and a visitor, for instance, a spouse, may not be considered abuse, but these should be addressed in the care plan and on an individual basis about whether it's abuse or not. Nursing home staff must immediately act on any allegation or suspicion that a visitor is engaging in any improper sexual activity with a resident. Sex offenders. Be interested to know that the Government Accountability Office found 700 registered sex offenders were living in nursing homes or intermediate care facilities for people with mental retardation, and about 3% of all nursing homes that receive Medicare and Medicaid funds have at least one sex offender during 2005. Your facility administrator does background checks on every employee and all residents before they are admitted to the nursing facility. The perpetrator gender. The gender of the patient may also be an important part of the assessment. More commonly, it's found in men, and more male patients are referred for treatment. It's interesting to know that the best estimates is about 7% to 25% of all demented patients exhibit inappropriate sexual behaviors. This is a photograph of a cross-section of a normal brain. This is the cross-section of a brain where the person had Alzheimer's disease. You can see that it's not, the parts of the brain are missing, and there's no way that it can ever be repaired. The dementia perpetrator, it's important to find out what kind of dementia they have, and that might be useful. The symptom of a brain injury or continuation of a lifelong sexual pathology. Non-pharmacologic or behavioral management, of course, is always to be tried and implemented first. And does the behavior fit a psychiatric syndrome? Anytime you have a dementia perpetrator, it's time to call in the clinical psychologist. Signs of sexual abuse: you need to watch for genital or anal infection, unexplained STDs, difficulty in walking or sitting, bilateral bruising of the inner thighs, bruising on or around the breasts, unexplained vaginal or anal bleeding, increased difficulty walking or sitting, and torn, stained, or bloody underclothing. Anxiety or excessive fear around the caregiver. The resident protection: if an incident has been reported, immediately protect the victim involved. Report the alleged violation to the administrator and the appropriate state and local authorities. You begin an investigation right then, and routine physical evaluation with possible vaginal and rectal exam are necessary, and those need to be done in the emergency room with rape kits. Please do not tamper with any evidence. You may want to get the resident washed up. You may want to get the linens off the bed and in the wash, but you do not do this until the resident is examined. Potential further abuse, neglect, or exploitation, mistreatment while the investigation is in progress. So you need to be paying attention and taking care of your other residents. Resident to staff aggression, RSA. We are at the beginning of a new wave. There's not a whole lot of information regarding resident to staff aggression. But you're going to see more and more investigation of this. It's common. 15.6% residents are aggressive towards usually CNAs. The American Nurses Association reported that RNs ranked job assaults as one of their 3 greatest safety concerns. Nursing home administrators and staff do not report and frequently ignore resident-to-staff aggression. Why is that? Because we have come to believe that aggression from a resident is just part of the job, and we just get used to it, and then sometimes we fear retaliation from other staff members or from families. Resident-to-staff abuse. A study was done by Locke, and 18 types of aggressive behavior have been documented. Usually it's a young female nurse or aide. Sometimes it's racial and ethnic slurs. It's a real stressor for staff. It can cause physical harm, and it certainly leads to reduced job satisfaction and staff burnout, and increased risk for more abuse, neglect, and exploitation. If you've been hit or punched by a resident, it's never retaliate. Remember that the resident may not be responsible for their behavior, but you are always responsible for your own behavior. You need always to monitor, report, and document and stop the abuse towards staff. This is one of those times that you need to document. Resident to staff, it usually occurs in the resident's room during morning hygiene and care. You know, a lot of us would not like to be wakened up at 6 o'clock in the morning and drugged to the dining room. It's interesting to know that the non-white, African American, and Hispanic residents are much less likely to be aggressors. Resident-to-resident abuse. Remember, I told you that this is more common than we thought in long-term care. The aggressor characteristics usually have a higher level of cognitive awareness and function. That's who does the aggression. They may have a history of aggression. The victim characteristics are that they're cognitively impaired, they're usually female, and wandering is a problem. When we have a resident who wanders around, they violate space of other residents. And for instance, you could have a resident who's never been abusive, but she walks into her room and another resident is in there disturbing her things. The commonalities are that occurs in the afternoon hours. Now, resident to staff is usually in the morning, but it's during the afternoon hours that resident to resident abuse usually occurs. So we need to be more observant of what's going on. It's usually in the common areas where residents are interacting with other residents, and you've got space issues and noise issues, communication issues. Involuntary seclusion. We never separate a resident from other residents and confine them to their room, with or without roommates. That is against residents' rights. Now, you can sometimes in short-term monitor separation. You're trying to separate the two residents, and you might need to send them to their room for a short amount of time until things cool off. Abandonment. This seems to be a problem for nurses and aides in hospitals more than in nursing homes. But it's the desertion of a vulnerable elder by anyone who's assumed responsibility for the care or custody of that person. You know, when we talk about this in the nursing home, abuse and neglect and exploitation, but it occurs out in the community, and you're just as responsible out in the community to pay attention and to report incidences of suspected abuse. Neglect. Neglect is the refusal or failure of anyone responsible to provide food, shelter, health care, or protection for that vulnerable adult. CMS says that the failure of the facility, its employees or service providers, okay, people who come in to provide service, to provide goods and services to a resident that are necessary to avoid physical harm, pain, mental anguish, or emotional distress. Active neglect is when someone intentionally fails to give the care, fulfill their responsibilities. Passive neglect is unintentional failure of a caregiver to fulfill his or her caregiving. Now, this could happen, for instance, you're new on the floor and the resident has to have their milk carton opened in order for them to drink their milk, and you're not aware of that, and so you leave the tray, but you don't help the resident. That is neglect. Neglect is the failure to provide clothing, food, hydration, incontinent care, medical care, medicine, oral care. That's something that I would take very personal. I just can't imagine getting up in the morning and being taken to the dining room and not having brushed my teeth. Range of motion, regular baths, repositioning. Can you imagine what it would feel like to be lying in bed and not be able to move? And even if we reposition them every 2 hours, that's a long time to lie in one place. Scheduled toileting, shelter, supervision. Neglect examples are ignoring a resident who's confined to the bed or the wheelchair. And that's real easy to do if they're not interacting with you. Performing a task inappropriately, and I find that doing that, not doing the job the way it's supposed to be done, is because we get in routines and we get to the point where we want to save time, and so we don't do it the way we should. This is important, doing a one-person transfer when it needs a two-person transfer. And I know this is difficult sometimes when you're the only aide on the floor, but that's no reason to do a transfer when you could get injured and the resident could get injured. Go get a nurse, go get anybody to help you, but do not do a one-person transfer by yourself. Turning off a call light, not taking care of the resident, that's pretty obvious, and ignoring a resident when they need help with food or a tray. Isolating a resident. Now, self-neglect happens out in the community, and it leads to illness or injury, and those kind of behaviors are things like hoarding and poor hygiene, dehydration, confusion, not able to take care of your house, wearing unsuitable clothes, leaving burning stoves unattended, failing to take medications. And see, that's something we need to pay attention to out in the community, and seeking medical treatment. Can the person get to the doctor, or do they just don't know to go? Exploitation. Exploitation is probably the number one kind of abuse out in the community. And that's illegally taking or misuse or concealing funds or property that belong to an elder adult. Exploitation. Residents have exactly the same right as anybody to receive, spend, invest, save, or give away their money. A family member or friend or nursing home may not take control of the senior's money without that person's permission. Taking advantage of the resident for personal gain by either manipulating or intimidating or threats or coercion. Signs of exploitation may be abrupt changes in a will or other financial document, unexplained disappearance of funds or personal possessions, discovery of an individual's signature being forged. And scams also include, and I've had this happen, get telephone calls or emails saying that you've won a prize, but you have to pay money to claim it. And then, of course, phony charities. Misappropriation of property is the deliberate misplacement, exploitation, or wrongful temporary or permanent use of the resident's belonging or money, with or without permission from the resident. I personally know of a case where uh, uh, an employee of a nursing home had a relative in another state, and her cell phone, she could not call without paying a fee. And so the resident offered this employee to use her cell phone. And so the employee took the phone and called her sister. Later on, the resident's family found out about it by seeing the telephone bill and went to the nursing home and asked about it. This is exploitation, even though that employee had permission to use that telephone. It is still a deliberate, wrongful use of that resident's belonging or money. Healthcare fraud and abuse. Healthcare professionals charging for service that are not provided to the resident. That's fraud. The statistics show us that older adults who are abused and neglected are 3 times more likely to die than those who are not abused. Older adults who suffer from self-neglect are nearly 2 times more likely to die than those who do not. Who do you think does the most abuse? If you've taken the test, you'll see that most of the time people think it's the spouse, but actually it's the child. But you can see that most abuse is done by family and relatives. The facility has 0 tolerance to abuse. They have 7 components that they must follow for abuse prevention. They need to prevent it from the start. They need to do careful employee screening. They need to identify abuse. They need to train their staff. They need to protect and investigate any allegation of abuse. They need to report and respond to that allegation and then continue investigation. Nursing home systems have problems, and usually it's inadequately trained staff or high turnover. And a lot of times in this area of the country, we don't have enough people to fill those staff positions. High resident populations such as Alzheimer's or other dementia. Alzheimer's patients and dementia patients take a lot more time and a lot more care. High resident population with increased needs. Trachs, residents with heart failure, kidney disease, all those residents take more time. You need to view certain incidents. Viewing certain instances of abuse and neglect are normal. That is not normal. The physical environment, long hallways, poor lighting, distances between the dining room and residence rooms. I find that being out in the hall trying to count out medications and give medications in poor lighting is really difficult. The types of staff abusers, oftentimes they're just overwhelmed, either with the job itself or with things that are going on in their home. And they can be impaired. That doesn't mean necessarily alcohol or drugs, but just physical impairment. Narcissistic, meaning that they are the most important thing in the world and the residents and the other staff members are not as important as they are. Bullying, we hear more and more about bullying behavior. And then sadistic behavior, which is just being plain mean and trying to hurt somebody on purpose. The staff factors are staff-to-staff bullying. We need to pay attention to how we treat other people on the team. Resident-to-staff aggression, that's hard to take. Personal, everyday life issues. We never know what happened before that other staff member came to work that day. It could be a sick kid, it could be their mother's ill, they could be having marital problems, their car wouldn't start. It's all kinds of things that can get you off track. The other thing is seeing residents as tasks. 10 baths, 8 feeders, they're no longer people. We just see them as things to do. Published studies show that people who work in nursing homes have a higher burnout than anybody else in different professions. Staff reports work conditions are not conducive to providing patient-centered care. And then 47% of nurses report their workload causes them to miss important changes in condition. And this is one of the times that I wanted to say that the person who can spot a changing condition is the aide who is used to taking care of that resident. The direct causes of staff burnout are work overload, or not being able to control their schedule, or not having a lack of authority. They can't seem to be in control of anything. Insufficient reward. They don't get recognized for their contributions. They don't think they get paid enough, and they have few opportunities for advancement. The absence of community. We need to remember that we're a team, and we need to work together. And we need to depend on our administrator and our supervisor's support. And then there's difficulty with the nurse-physician communication. One of the things I'd like to share with you is that this has helped me through many years of my nursing career. I was working in ICU, and I was a good ICU nurse, and a patient went into VTAC, that's a fatal arrhythmia, and I called the doctor and said, I think Miss So-and-so is in VTAC. Now this doctor and I got along usually really well, and he said, Bonnie, is she or isn't she? And I thought, well, I think she is. So he came to the unit, and I noticed that he was at the nurse's station and wasn't really making eye contact with me. And so I walked up to him and I said, you know, my goal for the day wasn't to irritate you. So if you will just tell me what it is that I've done that has made you unhappy, tell me, and I'll try really hard not to do it again. And he said to me, Bonnie, listen to this. I think Miss So-and-so has VTAC, or in my best nursing assessment, this patient has VTAC. Do you hear that? In my best nursing assessment, which indicates that I got vital signs, I paid attention to her symptoms objectively, and then called him my best nursing assessment. And so any time that you're talking with a physician and you've done an assessment, tell them it's your best nursing assessment. It doesn't even matter whether you're right or wrong, as long as you assessed. The emotional demands of the work itself, and that can be overwhelming, the people that we're working with, and knowing that there's no cure and that they have chronic diseases that we really can't do anything about. The signs of burnout, you know, I don't need to go through that. There's physical signs, headaches, being tired all the time, emotional, being cranky or crying, behavior signs, acting out when things aren't really that bad. We need to prevent abuse and neglect and exploitation, and we can do that with communication techniques, which is listen. You know, when I became a nurse practitioner, one of the doctors told me, he said, you know, you can make a diagnosis. The patient will tell you what's wrong with them if you just listen long enough. We need to provide more choices in our cultural change where residents are getting more and more rights and more independent choices. We need to remember to provide those choices. We need to talk through procedures. We certainly don't want to turn somebody to do wound care without telling them what we're doing first. We need to address complaints from the resident and the family and be mindful of our body language and voice. Come back later if no cooperation. And you know, I cannot tell you how important it is to make eye contact with whoever you're listening to and whoever has a complaint, especially family. Listen to what they're saying. Even if you can't do anything about it right then, say, I hear what you're saying. And then sometimes if they go on and on, you can say, I hear what you're saying. Now I need to process this. Give me time, and then walk away. You need help. Ask for help. Ask for help if the resident behaves aggressively. Ask for help when the task requires two people. Ask for help when communication is not working with a resident. You know, we all have residents that we can get along with and seem to like us better than other caregivers. And the same thing happens the other way. You might have a resident who cares for another staff member. So go to that staff member and say, I'm not having much luck with Miss So-and-so. Will you come and talk to her? Ask for help when the workload is too much. You know, one of the best teams I ever saw was on a surgical floor with the aides. They never went into a room by themselves. They always had someone with them, and they got their work done twice as fast. Help the other person when they need help. Preventing abuse and neglect. We need to do individualized care planning. I know that sounds like it's overwhelming, but one of the things that we do is we put too much and make the care plans too long. We need to make them appropriate to that one person that we're doing the care plan for. The person-centered is a process directed to the family or individuals with long-term care needs. The resident and the family are equal partners in planning care. And important, it's in addition to the resident, a facility staff, including the CNA, should be present during the meetings about the care plan. It only makes sense that the aide should be in those meetings because who knows more about that resident than the aide? Is abuse or abuse potential in the care plan? Has the abuse potential care been planned? What is the behavior? Was there confusion? Is there a lack of social interaction or family interaction? And you know, one of the things I want to point out to you is that if you want to know that a family is abusing or verbally abusive to a resident, ask housekeeping. Because for some reason, housekeepers are invisible. A family can be abusive to a resident and the nurse can walk in, the aide can walk in and it can stop, but for some reason nobody pays attention to housekeeping. So if you want to know what's going on between residents when you're not around and family when you're not around, ask housekeeping. So who's the abusive coordinator? I promise you, you must know who the abusive coordinator is. Everybody in this facility needs to know who the abuse coordinator is. Every employee in the dining room, physical therapy, activity director, you, CNA, everybody needs to know who the abuse coordinator is, because I promise when the surveyors come in, that's one of the questions they're going to ask anybody. The abuse coordinator in this facility at this time is your administrator. They monitor the staff to assess care and services make sure that neglect isn't occurring. They determine injuries of unknown origin, investigate it, and see if there are allegations of abuse. They need to ensure that residents and family feel free to report concerns without any fear of reprisal. The facility has procedures to report any alleged violations of abuse to the state agency, and they take all necessary corrective actions depending on the results of the investigation. They also need to report to the state nurse aid registry or licensing authorities any knowledge that it has of actions of law would indicate an employee is unfit for service. You also need to know that it isn't just nurses who get reported. Any employee who is allegedly abusing a resident is reported to the state registry, and that protects residents in other facilities. If we didn't report that, then that person could just leave this facility and go to another facility and get a job. And that also means that they may be an aide in this facility and go in housekeeping in another facility. They still cannot obtain employment if they have had been reported. Staff challenges is reporting confidentiality protection. You need to find privacy away from others from hearing, and if you're concerned about that, I'm going to give you a hotline number that you can call from home or anywhere where it's quiet or where nobody can hear you. Because sometimes we have a fear of retaliation. Either the resident and the family can retaliate against you. And believe it or not, other employees may not like that you are reporting that they've done something that you consider abuse. Response to the allegations of abuse. All allegations of abuse, neglect, or seriously bodily harm, and I'll give you the definition of that, and injuries of unknown source must be reported immediately, not later than 2 hours. Okay? If you have any doubt at all that someone is being abused, it needs to be reported in 2 hours. Not later than 24 if the events that cause the injury don't involve abuse or cause bodily harm. You can report to the administrator of the facility, and I certainly would tell you to do that. The state survey agency, all evidence must be thoroughly investigated, and to prevent further abuse while the investigation is in progress, you need to suspend the alleged perpetrator immediately. That means if you think somebody has abused a resident, they need to leave the building right then. Be escorted out of the building. Because if you don't do that, if you let them stay another half hour, then the regulatory agencies think or could believe that somebody else was abused during that 30 minutes. Report the result of all investigations to the department and to APS within 5 working days. Nursing and staff responsibilities is that you need to recognize abuse and neglect and exploitation from normal signs of aging. You need to recognize the signs and symptoms of abuse. Then they're best identified by the person who knows the resident and is able to tell you what is normal. You document your observations and conversations according to your facility policy, and if the forms are required, use them. You have really good report forms. Fill them out carefully. Don't leave any blanks. Share your concerns with the individual identified in your facility, either your chief nursing officer, your administrator, the risk manager. When filing your report, do so accurately and completely, including all content the facility report requires. And you can certainly ask another nurse supervisor or district supervisor to help you with the report. Report all suspicions about abuse. Your policy and procedure and job descriptions and clinical protocols should be detailed. Vague won't do. You need to remember, I know I'm repeating this, but the facility has procedures to report all allegations of abuse, neglect, and misappropriation to the health department, DHS, and police if indicated. The nurse aid registry and all licensing boards must be notified immediately, and the results of the investigations reported within 5 days. Now, I told you that about serious bodily injury. This is so important that CMS has made a definition for it. Serious bodily injury is an injury involving extreme physical pain, involving substantial risk of death, involving protracted loss or impairment of the function of a body member, organ, or mental faculty, or requiring medical intervention such as surgery, hospitalization, or physical rehab. In the case of criminal sexual abuse, serious bodily injury harm should be considered to occur if the conduct causing the injury is sexual abuse, aggravated by sexual abuse, or any similar offenses under state law. So what we're saying is if there's any abuse that appears to be sexual, that is considered serious bodily injury. The time frames for reporting are abuse must be reported within 2 hours. Neglect with harm, 2 hours. Misappropriation, 24 hours. Neglect without harm, 24 hours. Certain injuries not involving abuse and neglect is 24 hours, and final reports are always due in 5 days. The staff involved in the abuse will be suspended. They must leave the building immediately. And it's okay to tell them that that's policy, that we don't necessarily believe that they've done anything wrong, but anytime there's an alleged suggestion of abuse, they must leave the building. The police are notified if it's indicated, and then you don't disturb any scene if it's a potential crime. Leave it be. Injuries of unknown source, report in 2 hours suspicious bruises, fractures without a cause, other injuries without a known cause, injury not in the usual location, like bruises inside the thighs. Extent of injury is unusual. The source of the injury is not observed, and the source of the injury could not be explained by the resident. So the summary of this is it's not your role to verify that abuse is occurring. You don't have to prove anything. If you suspect it, that's your role. If it's suspected, you need to report it. You need to alert others of your suspicions. You're not reporting abuse or neglect, just the facts, the incidents, the behaviors, or the conversations. You report what you actually see an incident that you suspect is abuse or see signs that suggest abuse has happened. It's mandated by law to report situations that may be abuse or neglect, and there are federal, state, and nursing organizations requirements for reporting suspected A&E. The Oklahoma State Department of Health investigates reports of abuse, neglect, and exploitations in nursing homes. That's who looks out for it. The Adult Protective Service will investigate or abuse or exploitation allegations involving nursing home residents, but the abuse of a senior who's not in a health care facility can be reported to APS. If the victim's in immediate danger, call 911 or your local law enforcement agency. And here is the Stonegate hotline. You can use that at any time. You don't have to report to the administrator, the nurse, or anyone. If you're concerned about retaliation or you're embarrassed about it or whatever your reason, you can call 1-800-399-5556. The Oklahoma Department of Health is 1-800-747-8419.